Welcome to another episode of the Stroke Busters podcast, your go-to source for all things related to stroke, research, community, and academia. I'm your host, Amy Quinn, Communications Director for the UT Health Houston Institute for Stroke and Cerebrovascular Diseases. Today's episode is a part one of our Yatsuday series, bringing you an inside peek to the speakers who will be presenting at the 14th Annual Yatsuday Symposium, presented by the Stroke Institute here in Houston, Texas on November 10th, 2023. The theme for the 2023 symposium is Nurturing Brain Health and Preventing Stroke. So this event will help increase physician and trainees' knowledge in lifestyle modifications, mental well-being, and brain health education for patients. Topics are going to include things like nurturing brain health, preventing stroke and dementia, risk predictions for stroke, identifying stroke risks using artificial intelligence, cognitive testing, sleep, brain health, and more. It's going to be a jam-packed day. We're excited. This program is accredited for continuing medical education and nursing education. So we're wanting to cater to a diverse spectrum of healthcare professionals. So if you are a physician, nurse, occupational therapist, physical therapist, speech language pathologist, family medicine, PCP, and internal medicine healthcare providers, anyone who works closely with individuals affected by stroke and dementia, we want you to come and learn more. And additionally, it's valuable for those who have an interest in brain health, health promotion, and stroke prevention. And this year, a very unique element that we're adding is interactive sessions. We're going to have people from UT Health Houston, Memorial Hermann, people like James Grotta, Miriam Fornage, Angel Sharif, Heather Smith, Kendra Anderson, Seema Agarwal, and more. And you can also anticipate insights from globally recognized experts in the field of stroke care, someone like Vladimir Hachinsky, who will be our guest for today's show. He is an eminent figure in the world of cerebrovascular diseases and stroke research, with over 5 decades of experience and a treasure trove of knowledge. So we are thrilled to have him on the show. And as an added bonus, Dr. James Grotta, who we have had on many times before, was gracious enough to sit with us to ask Dr. Hachinsky some questions about his involvement at Yatsuday. So let's get to it. Enjoy. And if you're interested in attending Yatsuday, visit uth.edu/stroke-institute. Click on the events tab at the top of the page to find the Yatsuday link, and you'll get all the information. So with further ado, here's Dr. Grotta and Dr. Hachinsky.
Well, it's my pleasure to have this conversation with Dr. Vladimir Hachinsky, who has been one of the pillars of vascular neurology and been involved in the field from its inception. Many people don't realize that really the first clinical trials in stroke were done in stroke prevention with the carotid endarterectomy studies done by Dr. Hachinsky's colleague, Dr. Henry Barnett, and Dr. Hachinsky. So maybe we should just start off, Vlad, by, from your perspective, doing clinical research and in the early days of your career, how you got started in that journey.
Right. Well, the first one is that when I started, many people thought that stroke were untreatable. And in fact, there was a correspondence in the British medical literature sort of saying, should they be admitted to hospital anyway, because there's nothing we can do about it. Now, there was an attempt to reverse that, and there were 2 acute stroke units that were open in the United States, but they were closed because they did not seem to help patients. Now, my colleague John Norris had the idea that he wanted to establish a stroke unit, and you can imagine going to administration and saying, look, there are 2 failed acute stroke units, but we want one. But by luck, he had a patient who gave $1 million in the 1970s. Now in Canada, that was a huge amount of money. So we're able to build a stroke unit of 5 beds. And there were probably 3 reasons why we didn't need statistics to see that we're helping patients. The first one was that either John or I examined every patient every day. And we're able to correct things that go wrong when a stroke has a patient. You know, the hydration is wrong, then the electrolytes, you know, the chemicals in the blood are different. People may have blood pressure changes. And so we jumped on those things and looked after them. So that was one. The second one is that we asked for volunteers, volunteer nurses, volunteer physiotherapists. So the people who volunteer are keen. They want to learn something. And so we had a very good team and we learned together. So that was very important too. We were important that we weren't in the medical side, but the nurses' affairs are important. And there was a third component that we didn't realize how important was at the time, and that is I had a neighbor called Joe Somerville. And she said to me, Vladimir, what are you going to do about rehabilitation? I said, I have no idea about rehabilitation, except that I know it's important. I tell you what, I'll talk to John, and if he agrees, you come every day to the stroke unit and you can decide which patient needs what. And she had this philosophy that rehabilitation begins in day one, and she mobilized the patients. And now we know that was a good thing to do. So by coincidence, all of a sudden we have something that worked. Then the next thing is that at the time, the only medication that was being prescribed are high doses of steroids. So the original stroke unit was in Toronto with John. And then I was recruited to London, Ontario by Dr. Barnett. And I established the second stroke unit. And between the two stroke units, we did a trial on high dose steroids compared to controls. And we showed not only was it useless, it was dangerous because people got infections and complications. That was the end of that. And of course, thereafter, there are a number of innovations that came. I mean, imaging was an important advance because we knew more what the cause was. And then thrombolysis came in. And then thrombectomy came in. And now from a field where little could be done, we have a field that's growing and a lot can be done. And part of the reason is that in part the trials, I think Dr. Barnett, who you mentioned, was a pioneer in doing a surgical trial in that at the time, a lot of people were getting operated on narrowing of the carotid artery and removal seemed like a good idea. But then the question was, well, is that a good thing for all patients? So the initial results were that if it's really a very severe stenosis, it's worth doing. If it's less than that, it's not worth doing. So that was another advance. And then something that was not as dramatic was the fact that before 1970, stroke research was dispersed in different journals, and it was a small field. Then Dr. Millikan persuaded the American Heart Association to have a journal for stroke. And that was an important contribution to actually having, you know, the papers then were consolidated in the journal Stroke. And it was important then you were sort of one-stop shopping. If you went to stroke, you could know what was going on in the field. And another contributor was that there used to be every 2 years what's called the Princeton Conference of the leaders in stroke, and they often invited people from other disciplines. And they were and they were a special format by invitation only. They had half of the time were presentations, half the time were discussion. And I believe you hosted one, Jim. Is that right? A Princeton conference? Yeah.
Right.
Yeah. So I think that, you know, and so from a field where so another big change has been that well, you know, early on, we became very proud of the fact of how quickly we could treat a stroke and how well we treat a stroke. But, you know, then I thought to myself, you know, each successfully treated stroke is a triumph in one way, but it's also a failure. It's failure to prevent one. Can we do more for that? And so little by little, I shifted towards prevention. And also, of course, if you have a dramatic stroke that, you know, causes you to lose your speech or you use your arm or you lose your balance suddenly, by this I mean within seconds, then of course everybody knows and you got yourself to an emergency. But for each stroke we know about, there are 5 that we don't know about that affect the way you think, mainly the decision-making ability. It's called executive function, the ability to plan, the ability to problem solve, etc. So again, I became more interested in the idea of what I call the vascular cardinal impairment, which means any cause or risk factor for vascular disease, because that's the only part of the causes of dementia that we can actually treat and prevent.
Wow. So in the in those last few minutes, you've touched on about a dozen things that you have played a pioneering role, and I'd just like to hit on a few of them in a minute. But you refresh my memory about stroke units, which absolutely is right, and I do want to emphasize John Norris, who died recently, as a leader along with you in that area. And I do remember that the first trials showing anything worked in stroke was that the implementation of stroke units. And just to bring this back to the Yatsu Day, when here in Houston, we started one of the first stroke units in the country, thanks to Frank helping us support that in the hospital, and along with Elizabeth Noser, who is also one of the organizers of this of Yatsu Day, and the issue of bringing early rehab and integrating uh, early rehab into um, acute stroke care, and so that sort of there's a seamless transition was, I think, very critical. And then, of course, your leadership in the first really treatment trial for stroke, which was steroids, which, as you point out, didn't work, but it was a first randomized acute treatment trial that showed that we could do it. And then, of course, the endarterectomy studies, and then into dementia. So you were involved in a lot of things, but I'm going to refresh your memory. When I was a young assistant professor, we were involved in stroke prevention research, and we were doing the ticlopidine trials, and I was involved in animal lab stuff and acute treatment. And you and I talked at a meeting, and you gave me some advice. And you said, Jim, you should focus on one thing. Or at least you can't be too diffuse. You need to become knowledgeable and expert in one area. And yet you've just described so many different areas that you've been involved in. Tell me how what advice you would give to uh, young investigators starting off, because that was pivotal advice for me.
Yeah. Well, first of all, I will give the same advice, even I'm not a good example, but I'll tell you how I got involved in so many things. Lucky accidents. First of all, I was doing internal medicine in Montreal, and I was supposed to have a rotation on a investigative unit, where they admitted complicated patient, did all the tests. But then the radiologists in the province of Quebec, where Montreal is, were on strike. So they put me on neurology. And at the time, I was intrigued and respected neurology. After all, it has to do with the brain, but there wasn't much that one could do at the time, and so I hadn't been interested. But then, as I was on that ward, and then we had a patient who had meningitis, and we cured her. I thought, gosh, there is some treatment, and we could treat epilepsy at the time. So I became interested in neurology. So that was one happy accident. Then the next thing that happened was that because I already knew I was going to do neurology, I had an option of 1 month, whatever I chose. I chose neuropathology, sort of, and the neuropathologist said to me, in 1 month, you won't learn enough neuropathology to be any good to me, and it won't be any good to you either. Why don't you prepare the notes on stroke for the students of McGill University? So I spent the month reviewing the literature and making notes for the medical students. So I became interested in stroke. So there it was. And the third lucky accident was that already I was interested in stroke, and I got a scholarship to study cerebral blood flow in Britain, the Queen's Square, it's called, the Hospital for Nervous Diseases. And I wanted to study acute stroke patients. I was told that at that time, that stroke were not a neurological problem. They did not admit them. If I wanted to do a study, I had to do dementia. And I thought, oh my goodness, I'm not particularly interested in dementia. But they said, look, you have a choice, take it or leave it. So I took it. And then the fact that I didn't know much about dementia helped me, because at the time, everything was hardening of the arteries. There was a slow strangulation of the brain's blood supply. And then there wasn't enough blood for the brain cells, and they died, and you became demented. And there was a whole industry of drugs that are supposed to dilate the blood vessels. So first of all, not having, so I started looking at what was published, and I thought all this business about hardening of the eye, I don't think it makes sense. There are a number of holes here. But as far as I can tell, if you have dementia, you probably have multiple little strokes that affect different parts of the brain that make you think less well. And so I invented the term multi-infarct dementia, which turned out to be important, because even then you could prevent some strokes, and therefore you can prevent some strokes, you can prevent some dementia, because a stroke doubles the chance of developing dementia. So then I also decided to do the study that I described, and so I had two groups, one what I call multi-infarct dementia, and then one I call primary degenerative. That simply meant that I don't think anybody was smart enough just to examine a patient and say, well, there is Alzheimer's in your brain. But it meant that it was not vascular. And then I developed a little scale how to develop it, how to actually assess the multi-infarct dementia. So we published, and then I thought, well, if it's true that there is lack of enough brain to the cells, then it also means that some of the byproducts of breaking down glucose and using oxygen to fuel the brain, they would leave behind little byproducts that are acidic, and they dilate the blood vessels. So if it's true that this is a state where there is not enough blood, so ischemia is the technical term, then they couldn't dilate anymore if you give them something powerful to dilate the blood vessel, which is carbon dioxide inhalation, which is really very, very powerful in dilating blood vessel. So we did this study, they were identical. So that was the beginning of the end of that story about it being all hardening of the arteries. And then the idea of multi-infarct dementia caught on, but then people shifted their interest from dementia and looking at blood vessels to what's being called Alzheimer's disease. And so in some ways, we did too good a job, because then that was been neglected. And so, my struggle since then has been, so look, vascular is important. They're connected to dementia. That's the one thing we can change. And then the other thing that happened is that they attached my name to an ischemic score. So my name was in the literature early on. And so that was helpful, because then people could recognize me. I had opportunities I wouldn't have had otherwise. But then again, that's luck. I mean, it's a question of timing. And then that other ischemic scale also made me think about what's actually going on in the brain. And that is, they found there were studies that were done in which they showed that the scale was very good in identifying Alzheimer's disease as something that was not vascular. But it wasn't very good at distinguishing when it was pure vascular and also had Alzheimer's. So then I thought to myself, it must mean that most brains in older people have both vascular and Alzheimer's pathology. And sure enough, that's true. And moreover, it isn't just vascular and Alzheimer's. There's a very good study from Chicago, Rush University, where they show that the typical case diagnosed as Alzheimer's disease has up to 8 causes, of which the vascular, the blood vessel one, is the only one who can actually prevent and treat. So that's how I got the interest in both areas, and that's how I've been lucky enough to do many things, in part because of luck, in part because I always work with other people. And so whenever I'm acknowledged, I'm very aware that I haven't done anything important alone. There always are people who help you. And some are recognized and some are not, like the nurses of the stroke unit or the physiotherapists. I mean, they're as important as we were at the time.
Well, that was a great explanation of how you can get involved in an area really in your early training and stay with it through your entire career. And I do think that the lesson is to focus in an area that's big enough to last a whole career, but focused enough where you can make a impact in it. And I think that you are a great example of that.
Yeah.
So with Yatsu Day coming up, we're going to not just talk about the past, but the future. So we only have a few minutes left, but maybe you can where do you think the field of vascular cognitive impairment or vascular dementia or dementia is going? Obviously, we see inroads in Alzheimer's disease, and there's the relationship between. I've just had a patient the other day with the genetically determined amyloid angiopathy with the transthyretin or whatever, however you pronounce it, gene mutation. And there's treatment now emerging for amyloid related a systemic amyloid that actually may cross the blood-brain barrier and conceivably could be effective for vascular amyloid. I mean, where do you see the advances coming in treating cognitive vascular cognitive issues?
Yeah. Well, there are two areas. I mean, the scientific area is going to keep advancing, and I think it's great to have two drugs that at least work in principle. They're too expensive and have the two serious side effects to be used widely. But I mean, that's an advance. And I think that of all the organs of the body, the brain is the least known. And the greatest advances in terms of science are going to be in understanding the brain. And so I think that we'll be more focused on specific causes of the brain. And I think that's an important front, and we'll see many advances. But in the meantime, we have what I'm calling an opening scissors crisis. Now, you're not familiar with the term because that's something that I started using. By this, I mean that the life expectancy is increasing and the fertility rate is dropping. In the United States, the average life expectancy is now 79. The birth rate is 1.6. In other words, there are 1.6 children per woman. Now, in order to keep the population steady, you have to have 2.1 children per woman. So at the rate we're going, even if we had a perfect drug that would stop cognitive impairment, that wouldn't prevent from younger people reaching the stage where they develop it. And I think that I've come to the conclusion that we have to begin now implementing holistic brain health. Now, what do I mean by that? Holistic brain health is when you're thinking, you're feeling, you're connected with others is the best it can be. And I think that the other thing we need to do is to develop things that are simple enough that can be done by most people. Most of the recommendations that are made by most of the health agencies are just not practical enough. And so what we're trying to develop here at my center is what I'm calling the minimum for maximum. It's the basic idea that 20% of the payoff comes from 80% of the payoff comes from about 20% of the effort, roughly. So for example, in activity, well, if the biggest gain is if you get off your behind and start moving. That already is a health benefit. People who do that live longer. So if you manage to do 3,000 steps, then your risk of premature death goes down. If you manage 3,800 steps, your risk of dementia decreases. If you do it with someone else, it doubles the chances you continue to do it, and also gives you the social interaction, which is very important. And if you do it in greenery, you get additional benefits. The Japanese have done a crucial study in which they showed that if you walk in greenery as opposed to a city, then your anxiety level goes down. They measure the cortisol in the saliva, very good measuring. Your heart rate goes down and your blood pressure goes down. So this is the sort of thing that we need to develop. And then again, in the diet, we have to know that a lot of people have low incomes and there are a lot of marginalized people. So there are lots of good diets where people can afford it, but what can a poor person do to have a healthy diet, or at least change part of it to have a healthy diet? So I'm very much now committed to preventing together both stroke, dementia, and ischemic heart disease, because they share the same risk factors, for which high blood pressure is the same. There again is a big opportunity of doing something, because the chances of developing high blood pressure in the United States is an average of 82%. The people at the lowest risk are 69% of white women, and the highest is Black African Americans and it's 86%. So most people will develop high blood pressure at some stage in their life. Now, only half of the people who have high blood pressure know that they have it. Part of the reason is that the mean age of onset in the United States is 46 years. So how many 46-year-old people check their blood pressure? They don't. And of the people who know that they have high blood pressure, only a fraction have it well controlled. So there's tremendous opportunity for treating hypertension and decreasing the risk of what I'm calling the terrible three. And I think if we all begin practicing, and the other good news is that it has been shown that if 10% of the population changes their behavior, change happens fairly quickly. Things catch on. And so, the example, and I think most people know is, certainly when I started my career, the majority of men smoked, and about a third of women. Now it's rare. I mean, you look at somebody smoking, you look at, oh my goodness. And also things have changed in terms that we're more aware of what's healthy. And there are people who run, there are people who do other things, but that's a small fraction who are already conscious of health. I'm much more interested in reaching out to the people who need for us to identify them at risk and help them.
Well, so that fits that. Thank you for that. Our time is up, and we're going to have to end this. But what you say fits in, of course, perfectly with the goal or the focus of Yatsude on promoting brain health and preventing cognitive impairment. As you know, this is the whole message now of the American Academy of Neurology's focus is on looking at brain, no longer focusing on disease, but promoting brain health by proactively doing all the things that you just so nicely outlined. I'm going to end now, and instead of going to work out in a solitary way on my Peloton bike in my gym, I'm going to go out to the park and run with my dog and talk to him as I'm running. So thanks for these insights, and we look forward to your visit here in Houston.
Likewise, looking forward to seeing you in person and seeing old friends. Bye for now.
And that is going to do it for this episode of Stroke Busters. We are so excited and elated for Dr. Hodzinski and Dr. Grotto to be joining us on Yatsude, November 10th, 2023. So again, if you're interested, learn more or share with colleagues who may be in the area around that time, it's uth.edu/stroke-institute. As always, ideas and opinions expressed on this podcast are our own and are not a substitute for medical advice. Always contact your doctor before starting any program or therapy to make sure you're getting the best care tailored to your unique situation. UT Health Stroke is on social media. Don't forget, follow us on X, formerly known as Twitter, LinkedIn, Instagram, and Facebook at UT Health Stroke. To stay updated on upcoming episodes, Yatsude, conferences, events, special guests, remember, share with colleagues, friends, and family. For updates and the latest news on the Stroke Institute, go online again to uth.edu/stroke-institute. And thank you for joining us again for this enlightening conversation. Remember, your brain health matters, so stay tuned for more in-depth discussions with Yatsude speakers. Remember, we're on social media, so keep track and expect more expert discussions on preventing stroke and dementia. Until next time, keep those minds sharp.